All right, so thank you. Thank you, and welcome back to the people who are here from the first NeuroVerge webinar, and hearty welcome to a lot of you who are joining us for the first time. Just a couple of housekeeping things before we get started. We loved your questions. We had a lot of really good ones come in the last one. We want to make sure we collect them all in the same place. So if you're asking a question, make sure you're sending the question to me directly and not just to the general population. That'll make sure that we see it gets addressed in the Q&A, and that I make sure that the appropriate person answers it, because some will probably come to myself or Jeff, and some will probably come to Dr. Brown. This is being recorded, as you know. We'll email it and post it to you in a few days. And just to get started, an introduction to who we are. So we have Jeff Moore joining us from Divergence Neuro. He's our COO. I am Lori Jeanin, the Director of Customer Success. And it's my pleasure to once again introduce you to Dr. Nathan Brown, who is hosting and is going to take us through the webinar.
Great. Thank you, Lori. Thanks for the introduction. It's very good to see familiar names and faces, mostly names right now. I think we're kind of blanked out here. I am really pleased to start this second part of the second part of our series, the NeuroVerge webinar series. What we did last time, those of you who are here will remember, in part one, we basically explored the idea that becoming a neurotherapist, or at the very least, understanding something about brain functionality, will make you a better psychotherapist. And for me, that's kind of at the heart of this entire series. I'm a clinician. I've been doing psychotherapy for many years and doing neurotherapy for many years. And I have come to have a really strong appreciation for how awareness of brain functionality can make you a better therapist, regardless of what kind of orientation you might have. And in fact, as I've worked with other people in different healthcare professions, it can make you a better MD. It can make you a better chiropractor. It can make you a better acupuncturist. There is a lot of really practical information in the domain of neurotherapy. And I'm hopeful that this series is going to help us unpack some of that together. So today, we are starting right at ground level, and that is looking at the implications of neurofeedback for psychotherapeutic models, especially as they relate to anxiety. You don't get any more basic than dealing with anxiety as a psychotherapist, or really any healthcare professional nowadays. And so that is going to be our topic today, is strategies for anxiety. You'll notice here on the right, before I move ahead, you'll get kind of a glimpse into the topics that we have moving forward. We've organized this as an integrated series. These topics somewhat build on one another. We're trying to create a narrative that will deepen as we go. And I'm very aware that there are people in the audience. Some of you have been practicing neurofeedback. You've been neurotherapists for many years. You have a deep understanding. I'm hoping there will be some ideas in here that will be useful for you. I'm also aware there are people attending this webinar series who are brand new to neurotherapy and neurofeedback. And I just want to say you're in the right place. We're going to give you some information that will kind of introduce you, get your feet wet on this topic. If you look to the left of the slide, we're going to start right there. I'm going to give you neurofeedback in 90 seconds. I've set this as a personal challenge for myself. I think I was probably at about 120 seconds in the first webinar. We're going to see if we can do this in 90 seconds. And those of you, even if you already have a deep understanding of neurofeedback and what it is, you are welcome to listen and see if maybe there's some language that you can borrow as you communicate this to your patients. So we're going to kind of ground this in a common understanding of neurofeedback and what that is, what the basic principles are. And then what I'd like to do is just pull the camera back and look at anxiety through the lens of different traditional psychotherapeutic models. Many therapists in this audience that practice from different perspectives different theoretical perspectives, and you are aware, as I am, that anxiety is conceptualized a little differently in these different models. We're just going to review that so we have a bit of context about what I might think of as mental models for anxiety, ways the mind experiences anxiety. And then we're going to contrast that with a brain-based view. What's happening at the brain level? A little bit later in the webinar, you'll see a picture of a sailboat out on the water in Puget Sound. It's actually my sailboat, one of those remarkable moments I actually had time to get out on the water. And I often use this as a metaphor with clients that your mind is sort of like that boat out there on the water. You are aware of the surface of the water. You're aware of maybe some chop in the waves. You're aware of wind and sun, and there are these different factors that you're taking into account as your sailboat navigates. That's kind of how our conscious selves operate. We're paying attention to different elements in the environment. We're paying attention to what our sailboat is like, what the characteristics are of that boat, what it can and cannot do. What we're maybe only dimly aware of is what's happening beneath the surface. In the Puget Sound, you can have very strong tides and current that are flowing right below the surface of the boat that are affecting your progress as a sailboat, but you may not be directly aware of it. You're not going to be aware that there may be a pod of orcas that are swimming just below your boat. There's a lot of things that are going on at sort of a brain level that we are either unaware of or perhaps dimly aware of. Neurotherapy and neurofeedback is a little bit like having a periscope that allows us to kind of take a look under the surface and see some other factors that kind of enhance our understanding of that, of what the conditions are around that sailboat. So this kind of a guiding metaphor I often think of and share with my clients, especially because I have a view of the Puget Sound, so I can point to sailboats as we go through. So after we've done that broad overview of a traditional psychotherapeutic view of anxiety and then a brain-based view, I'd like to just introduce a couple of distinctive brainwave patterns that have been identified in research and clinical practice as underlying particular forms of anxiety. And we're going to kind of approach that from a neurofunctional perspective and follow that by discussing treatment implications of a brain-based perspective on anxiety. I'm going to try and do that in a way that kind of attends to the brain aspects as well as the psychotherapeutic aspects and how those can integrate in treatment of someone who's suffering from anxiety. Finally, I'm going to give you some specific case examples with some actual data, and we'll kind of round out the webinar part of the discussion part of this, the presentation part with those case examples, and then we'll take some time for questions there towards the end. Okay, let's proceed then. Neurofeedback in 90 seconds. Here we go. First principle, most lay people are aware the brain is an electrical organ. This is an organ. Actually, all of our organs are innervated with nerves that have electrical impulses, but there is a very dense pattern of electrical activity that's occurring in the brain at all times. We have generally found that one of the most common ways of thinking about the brain's electrical activity is in terms of frequency and amplitude. Sometimes I describe this to my clients along the lines of music. Music consists of frequency and amplitude. Frequency, if you're plucking the A string on a guitar, that's frequency. That has to do with the speed of vibration of a particular electrical impulse. Amplitude has to do with volume. If it were music, it would be how loud you strum. And so frequency and amplitude are two very important characteristics of brainwave patterns. And neuroscientists have used those variables to identify some pretty distinctive patterns that occur across the brain that have some connection to behavior and emotion and so forth. Okay, the third element is homeostasis versus dysregulated states. Homeostasis simply means balance. The brain is a complex system. Like most, if not all complex systems, they seek balance. Our brains seek balance. They seek to be in a state of equilibrium, and a state that is maximally efficient. Our brains have evolved for several 100,000 years as humans, and earlier than that with our more distant ancestors, to optimize homeostasis. Our brains have learned to take in information from the environment to optimize its function. And when we go through trauma or we go through something unexpected, we run into difficulties that we don't know how to address, we can move into a dysregulated state. Or sometimes you might think of that as suboptimal homeostasis, where we're in a balance, but it's a painful sort of balance. You may think of some of your clients who come to you and they are stably unstable. They're experiencing difficulties in their lives that they don't know how to get out of. Now, the way the brain moves in and out of homeostasis has to do with the fourth bullet point here, which is operant conditioning. I'm going to ask you to go back in your memory and think, those of you who took Psych 101, you would have heard about behavioral psychology, B.F. Skinner, the rat pressing the lever in the cage in order to get cheese. That is all operant conditioning. The basic principle is that an organism will tend to repeat a behavior if it's rewarded. That's the fundamental principle in operant conditioning. And when I say the organism, what I really mean actually is that organism's brain. The brain is the one that's figuring out information from the environment that will help it get a desired outcome. In the case of the rat in the cage, the desired outcome is getting cheese. So that rat learns to press the lever in order to get the cheese. In the broader case of neurofeedback, neurotherapy, the cheese is homeostasis. The brain wants to be in balance. At a very simple level, neurofeedback is nothing more than operant conditioning with a fancy gadget. We're giving the brain information about itself that it can use in order to learn how to find its way out of a dysregulated state and back into homeostasis. Okay, so that leads me to the fifth point here, which is neuroplasticity. When a behavior, a brain behavior, perhaps let's think of it that way, when a desired brain state is achieved and achieved long enough over time, that appears to trigger something that we call neuroplasticity. There is strong research evidence that doing neurofeedback at a certain point, you begin to develop these neuroplastic changes. You literally begin to change brain structure as we strengthen the circuits that are supporting that new behavior. The final point I want to make is that neurofeedback, and you'll notice sometimes I refer to it as neurotherapy, somewhat interchangeable terms, is an evidence-based practice. This is a complex enterprise. This is not something that you just kind of pick up and start doing. It does take a certain amount of training in understanding, for one thing, understanding each of those points I've just gone through. Each of those, actually, there's quite a bit of depth beneath them, quite a bit to learn in order to be an effective neurotherapist. But this is an evidence-based practice. We do work that is based on assessment. It's based on research, and we evaluate progress. It's one of the reasons I like to do neurofeedback, because I have an idea based on data as to whether we're actually moving the needle for the patient or not. Okay, I'm not sure how close I got to 90 seconds. Someone's keeping time, you'll let me know. Okay, let's just now pivot and talk about anxiety from a psychotherapeutic perspective. And I'm just basically going to compress about 10 graduate credits in psychotherapeutic models into 1 or 2 slides. I have put up here 6 different psychotherapeutic perspectives on anxiety and just given some basic representative definition as to how anxiety is conceived in each of these models. So for instance, if you're an existential psychotherapist, you have a fairly deep sense that anxiety is fundamental to life. that there's a fundamental sense of uncertainty and lack of control in life. And so much of what an existential psychotherapist is going to do in working with a patient is to help them, first of all, recognize that uncertainty, sit with it, be able to begin to accept living in that kind of uncertainty. There's a great deal of depth in what an existential psychotherapist would do. A humanistic psychotherapist is going to, in general terms, tend to think in terms of anxiety is stemming from a fundamental lack of self-acceptance and perhaps a lack of self-awareness. So if you are a Rogerian therapist, something like that, or you're somewhere in that humanistic spectrum, this is going to be more of your focus. You're going to be hearing what a client has to say through this particular lens, and operating on the premise that if we are not self-aware, if we lack self-acceptance, we are going to experience anxiety in living. Psychodynamic theory. Most of us have a general idea about psychodynamic theory. This is the whole notion of the unconscious, that we develop these unconscious conflicts. We tend to repress emotion. Much of this is sort of developmental in nature, develops over the course of child and adolescent and development. And that the process of psychotherapy is one of offering insight into those conflicts and giving the patient an opportunity to surface what might not be in their awareness so that they can come to an adaptation. I'm going very quickly. Each of these could be about a 4-credit graduate course at least. Internal family systems. This is you might think of it as kind of a descendant of psychodynamic theory. It has some connections to other models historically. This is kind of going into the notion that we sort of have different parts of ourselves, different internal parts, and those parts interact. Sometimes they work harmoniously, sometimes they work in conflict. Where there is conflict, either internally or with the outside world, you're going to experience anxiety. And so that is kind of the frame that an IFS therapist might use. Okay, interpersonal psychotherapy. This is something that is kind of one of my home bases in terms of the psychotherapeutic work I do. It basically operates on the notion that our sense of self and the way we express ourselves in the world arises out of all of the interpersonal interactions that we have had over the course of our life. We start to develop a sense of ourselves in the context of our interaction with other people. And so without being aware of it, we start to develop a pattern of response to other people that elicits certain patterns from them. So if I'm a particularly needy person, maybe I'm always leaning into the other person, trying to get some kind of support from them. What is that going to elicit? Well, in many cases, it will elicit distancing, right? That other person is going to tend to distance. What will that elicit in me? I'm needy. I'm going to keep pursuing them. And so you end up with a conflict that you're dealing with that is kind of arising out of these interpersonal patterns that you may not even be aware of, ways in which you're contributing to the problem that you're experiencing. So an interpersonal psychotherapist is going to be really wanting to look at, and even in the here and now, with that patient in real time in the psychotherapy session, address some of those interactions. Finally, cognitive behavioral therapy. Lots of us work in some form or another with cognitive behavioral therapy. This is, I could talk a long time about this. Cognitive behavioral therapy essentially has its roots in Stoicism, Greek Stoicism. That's another whole story. But it's essentially the notion that when we develop problems in living, generally speaking, it's coming out of either irrational or not useful beliefs in terms of our thinking and in terms of our resulting behavior. So the notion in cognitive behavioral therapy is going to be that we experience anxiety when we are carrying either negative self-talk or some kind of inappropriate belief about our situation. And that's producing anxiety because we're not actually getting the outcome that perhaps we want. Okay, so those, I've done that very quickly, and I may have been inadequate for some of you, as you look at your own particular orientation. There may be some things that I've left out, but I'm hoping for now you kind of get this kind of a 30,000-foot view of these different psychotherapeutic orientations. There are obviously many that are not on here. I just picked some representative ideas. And I want to just look at this chart very quickly and just acknowledge that what we're seeing here are essentially, these are essentially models that are looking at the person's conscious and unconscious experience, but kind of conceived at sort of a mental level, if you will, a mental and an interpersonal level. These are some a little more than others, but in general, these are not referencing particular brain states. They can be consistent with referencing particular brain states, and we'll see that in a moment. But there's not an explicit integration of what these theories would suggest with what a more brain-based theory of anxiety would suggest. We move to the next slide. I would assume that most of y'all in the audience would find some validity in most, if not all, of these perspectives. I certainly do. I think there's something to be said for every one of these. In many surveys, you find that one of the most common theoretical orientations that therapists endorse is eclectic, that people are just kind of picking from different ones of these perspectives. And I personally, I have a couple of home bases that I tend to operate in, but I will at times pull from different ones of these. So most of us will find validity in these. On the other hand, we're going to tend to settle on one or more as kind of our home base, as I was just saying. And if you're like me, you're going to discover that as much effort as you put into developing kind of a home base from a psychotherapeutic perspective that works for you, there are going to be cases where that framework doesn't quite satisfy, doesn't quite provide a fully explanatory model for what's happening with a given patient. Sometimes it doesn't give us a particular basis for moving forward with a client. I remember early in my practice having an individual that I was working with who had experienced very significant trauma. And I was attempting to work with her from an interpersonal perspective and also from a cognitive behavioral perspective. And it was a target-rich environment. She had many irrational, unhelpful thoughts in terms of her current life. She had a lot of what a cognitive behavioral therapist would zero in on in terms of maladaptive thinking about some of her early history, the trauma that she'd been through. And I did that kind of work with her and just found that we stalled. I had what I thought were brilliant insights, but they just didn't seem to connect. And when I hit that point, and I just ask each of you to consider, have you hit that point with clients at all? If you've been practicing at all, you have. You've hit a point where you've seen what appear to be just the most clear theoretical strategy that would be called for with a particular client. And yet then you find that it just kind of bounces off. It just doesn't seem to have an effect. For me, what that did actually was it forced me back to consider what was happening under the surface of the Puget Sound, as we were talking about before. There's that sailboat. I'm giving them advice on how to steer that sailboat, and it's just not moving. So that experience, that one particular client, forced me to consider what's going on underneath the surface. Is there something going on at the level of the brain that might help me address this stuck place that we are in therapeutically? So let's pivot now and talk about the brain. We're going to talk about a neurofunctional perspective. And this slide, I'm not going to spend a lot of time on this because all of us, if we're trained in healthcare in general and mental health in particular, you are familiar with the idea of the fight or flight response. You are familiar with the well, for some people, it's a licensing exam question, the Yerkes-Dodson law, which is that curve down there in the lower left. It's simply the notion that the way we are built, the way we are wired, our bodies and our brains fundamentally tend to respond to threat with a very distinctive pattern. And it's basically a function of our wiring. We have something called the sympathetic nervous system that runs in parallel to the parasympathetic nervous system, kind of two modes that our brains and our bodies function in. Parasympathetic nervous system is about down regulation. It's about relaxation, rest, repair, sleep. The sympathetic nervous system is about alert, arousal, fight, flight, flee, that kind of thing. And so these are very distinctive patterns. The Yerkes-Dodson law down there in the lower left is summarizing about 80 years of research that suggests that you can have too much arousal for effective performance. You can also have too little arousal for effective performance. So there's sort of a sweet spot of optimal arousal. And that point may vary depending on what the challenge is that you face. If you're a professional hockey player, you might need to be a little further up that curve than if you're a bookkeeper, but there's going to be an optimal point of arousal for an individual's particular situation. So this whole notion that we have a fight or flight response that is a function of evolution. Our bodies and our brains have evolved in such a way to optimize to deal with life and death threats. We're all walking around with cavemen and cavewomen blueprints inside. When we have an angry boss that we're dealing with, we're going to respond as if that's a bear coming after us, right? Our adrenal glands are going to start to pump out adrenaline. Our heart rate's going to go up. Our breathing's going to get shallow. All the kind of things that you would need in order to have the greatest chance to be able to either fight or flee successfully. That's the way we're wired. And with enough arousal, we begin to the front, I'm already going to the brain, the front part of our brain, which is making sense of things, is going to have to put a meaning on that. And chances are, if it's the angry boss, the front part of our brains is going to say, I'm really anxious. And so the label, the way it gets experienced is as anxiety. Now, you would have the very same physical response to some degree if something really great happened. If you had a surprise party, and all of a sudden everybody, surprises you and they give you a great present or something like that, your heart rate's going to go up. You're going to get more adrenaline. You're going to have, to some degree, that same arousal response, but we have a different context. And so the front part of our brains, the frontal lobes, where we're thinking, that is going to create a different label. Now I'm excited. I'm not scared. I'm not anxious. I'm excited. So there's a whole spectrum of psychological experience, and kind of at the primary thing we might think of is anxiety. But there's a whole spectrum of psychological ways we will label that, ways we will experience that underlying psychophysiological event. So kind of my premise here is summarized in that little box at the bottom, that if we get overly frequent, intense, or inappropriate activation of the fight or flight response, that tends to underlie most anxiety disorders. Okay, so this is kind of what's happening under the surface, below the water. We may have things happening at that more conscious or preconscious level that the psychotherapeutic models are describing, but under the surface, we've got this kind of tide, this kind of pull that is being driven by a physiological response. There's my sailboat. That's Bellingham off in the distance. And there actually was a pod of orcas that day that surprised the heck out of me. That's why I think of that model. Sometimes things come from the surface to the surface that we're not quite acknowledging. Okay, so let's just take a step back. Most psychotherapeutic perspectives are going to acknowledge, they're certainly going to have room in their theoretical frame for that idea that there's a fight or flight response. You're going to acknowledge that in a general way, that we do inhabit these bodies, they do tend to respond that way. And so often, most psychotherapists know how to teach breathing exercises. They know how to do mindfulness. They know how to do a lot of different progressive relaxation, a lot of different tools that can help in a general way reduce that fight or flight response that their anxious patient may be experiencing. However, now we're coming to the nub of what a neurofunctional perspective can add. Those psychotherapeutic models in and of themselves don't really tell you as a therapist much of what to do specifically in order to train patients to effectively downregulate as they go through their week. Doesn't give them much beyond that kind of general, do some breathing exercises, that sort of thing, which will be helpful, but maybe not as targeted as we could be. Secondly, there is an effect of high anxiety on the therapy experience itself. As it turned out, my client that I was describing to you a moment ago that I worked with for 6 months, and I had such wonderful insights and things I was doing with her to help her according to my psychotherapeutic models. What I finally realized was she was hardly hearing a word I was saying. I could have the best interventions in the world, but she was so anxious. Her mind was just ping-ponging around. At one point I asked her, can you repeat back to me what I just said? And she couldn't. She was just simply far too anxious to even access psychotherapy. And that kind of opens the door a bit to one of the things I want to explore in a lot of different ways in this series is how an understanding of neurotherapeutic principles, and in particular being able to do some brain training, can allow an individual to actually make better use of the psychotherapy that you're offering. Because if they're highly anxious, their body's ready to deal with a bear. They're not ready to take on a lot of the insight that you may be very willing to offer. Okay, let's get a little bit deeper. So we've got a kind of an old-timey diagram of the brain here. And I want to get a little more concrete. As I said before, a lot of us as therapists were trained generally, deep breathing. If you're hyperventilating, breathe into a paper bag. There's a number of things where probably most of us have learned to sort of deal with the broad experience of anxiety. We're going to get more concrete here. I'm just going to identify 3 locations in the brain here. And generally, neurofunctionality progresses from back to front. So I'm actually going to go from back to front. That's why I have them numbered this way. In the posterior, the back part of the brain, we have 2 structures, the hippocampus and the amygdala. The hippocampus is generally where long-term memory is stored and consolidated. The amygdala is a very interesting structure. In a very specific way, what the amygdala does is it functions as that alarm. It's right beneath, as you can see, the visual cortex. I always have my brain with me. The visual cortex is back here. If you see that bear or that angry boss, it's going to activate here. And you want to have the alarm right next to the visual cortex, right next to the auditory cortex for that matter, because this will fire off if there is a threat. In a sense, the amygdala sort of consults with the hippocampus. Do we have anything that looks like this bear? Yeah, that's a bear. The alarm better go off. So we have this alarm in the back that is really there to keep us alive. It's there to give us a warning. And that in turn moves us to the second location in the center, which is the limbic system. This is technically the middle part of the limbic system. The limbic system is kind of mission control for managing fight or flight. This is the part of the brain that then sends messaging out to the body very quickly to increase that heart rate and so forth. And the limbic system manages many, many things that are relevant to us as therapists. It manages stress-related physical conditions. You can get stress-related physical conditions with dysregulation here, because this part of your brain is managing physical homeostasis. It will affect attention. It will affect concentration. It will affect emotional regulation, and it will affect the limbic system, will affect how you deal with other people. Now, there's a lot to be said about those five. We're going to get to that in a later webinar. But for now, I just want you to hear the alarm goes off that fires up the limbic system here deep in the middle of the brain that starts managing this fight or flight response. Okay. And that messaging is very quick. Something like 5 to 6 hundredths of a second goes from seeing the bear or the angry boss and it getting to fire up the limbic system. And then you have an immediate response throughout the body. There's a slower pathway. As I recall, it's about 12 100ths of a second before that messaging gets to the front. And that brings us to the third part, the anterior, the front part of the brain, the left and right cortices. That's where you think. That's where we have executive processing, and it's about twice as long for that signal to get to the front. As I've said to some of you in training, this is why if you go to a baseball game and a foul ball comes at you, first you flinch, and then you go, what was that? That's because the flinching part is all this automatic stuff that's happening with the amygdala and the limbic system. The what was that comes later. That's the brain, the front part of the brain trying to make sense of what's happening. So notice that what we've done is we've established these three locations. You'll notice I wrote at the bottom, intentional oversimplifications ahead. The brain is actually a system. There's a lot of interaction going on here. In future webinars, I'm going to delve a little bit more into that. But for now, let's just think about these three sites. Okay, and now I want to talk with you about two different forms of anxiety. The first is amygdala-based anxiety. This is anxiety that is primarily driven because something has triggered that alarm, or that alarm is basically stuck in the on position. If an individual who has experienced trauma, like the patient that I had, that alarm, very good chance that that alarm is always on, that there's always what back in the day we would call free-floating anxiety. That is to say, a form of anxiety where you have at the very least this just sense of unease, perhaps the sense that something bad's going to happen. I don't know what, I don't know when, I don't know why I'm even thinking this. You know, it's a nice day and all of that, but I have just this hum of anxiety. That's generally amygdala-based anxiety. Okay, and you can tease that out somewhat in clinical interview. You can sort that out more definitively with a neurofunctional assessment, because that will tell you if, in fact, that amygdala is overactivated. If you follow the lines here, I'm trying to suggest here that the amygdala activates, that's number one, activates the limbic system. That's point 2 in the center there. And then the limbic system does what it does. It activates the body. It activates everything to go into full alert, or at least some level of alert. Okay, we're going to talk about amygdala-based anxiety a bit more in a moment. Let's go to the next one. This is cortically-based anxiety. Now, this is the low-hanging fruit for cognitive behavioral psychotherapists, because this is anxiety that is driven by activation in the front, some form of dysregulation in the front of the head where you're actually thinking. You can actually think your way into the fight or flight response as effectively as you can have it triggered from the back by that amygdala being overly activated. So in the front, there are, at a cognitive behavioral level, we might say there's maladaptive cognitions and so forth. At a brain level, we have an entirely different vocabulary. We start to look at a brain level at things like, is this person able to maintain focus? There are certain brainwave patterns that will tell us whether this is somebody who is able to maintain and sustain focus, or whether they're kind of ping-ponging around. Sometimes with my trainees, we talk about squirrel brain, where you're just kind of going to the next shiny thing or the next threatening thing. As it happened, my client that I was telling you about before had some of these characteristics, and I think I'll use the next slide to illustrate this. What I want to illustrate in this slide is that all of these interact. You can have a client with more or less pure amygdala-based anxiety. That person will be telling you, I'm anxious and I really can't tell why. Things happen, sometimes they're difficult. I'm not really thinking about them a lot, but I just always feel anxious. Chances are there's something more in the back of the head going on. Or you will have somebody that will tell you, I'm always running myself down. Or I'm always, sure that the worst thing is going to happen. They have some form of maladaptive cognition. And, that would be, as I said, kind of low-hanging fruit for a cognitive behavioral therapist. But it is quite possible, and in fact, the more time goes on, for both of these to begin to develop. Because the fact of the matter is, as one of my colleagues once said, the amygdala is watching Cortex TV. The amygdala is paying attention to all this activation that might be coming from the front. And pretty soon you have both. Pretty soon you have some activation in the back, you have some activation in the front. You have sort of two flavors of anxiety, so to speak, that are all activating that limbic system in the midbrain. Now, what I've described here, I'll just say in passing, this is, I'm giving you a taste of what a systems view of the brain is really like. Often because, we have to kind of ease our way into understanding complex things, we'll start by thinking about these linear connections. But the fact is there's an interaction. I love the book, A Symphony in the Brain. If you all haven't read it, you should read it. The one thing I would kind of nudge the author about there, and kind of in a friendly way, because the content is just great in that book. But the brain's not so much like a symphony as it is like a jazz ensemble. When you have a symphony, you have a conductor. And the idea is that the conductor is sort of telling the symphony what to do. In actual fact, the brain is more like a leaderless jazz ensemble, where you have some parts taking the lead at certain points and other parts, but there's an interaction going on. There's a continuously interacting system, which makes it complex, but also pretty amazing to consider. Okay, so I've got a couple of minutes here. I'm going to go quickly. When we use neurofeedback in the context of psychotherapy, generally what we're aiming to do, not always, but quite often, is downregulation. We're trying to help reduce anxiety, particularly in a case involving anxiety. However, we can do it in neurotherapy through brain-based pathways rather than what you might think of as mind-based pathways. And that leads to some very particular advantages for a neurotherapist who may also be doing psychotherapy or supporting another clinician who is doing psychotherapy for the patient. First of all, neurofeedback lets clinicians get specific. We don't have to be general. We can look at an assessment. I'm going to give you some examples here in a moment and have a pretty clear idea of where we need to target and possibly in what sequence. Secondly, neurofeedback puts the patient in the driver's seat. Neurofeedback is an empowering process. There's nothing more empowering than developing some control over this dysregulation. My patient I described with the traumatic experience, I did some neurofeedback with her to help her downregulate the traumatic activation that had been happening in her amygdala. And she felt so empowered to know that there was something she could do to actually stop that spiral. Okay, so neurofeedback can place the patient directly in control of their own outcomes. Neurofeedback also increases self-awareness. It is really hard to do neurofeedback if you're not developing some aptitude for paying attention to what's happening inside of your own body. And that, in turn, promotes a really strong sense of self-efficacy, in my opinion. I happen to believe that one of the most key aspects of mental health and resilience is the degree to which you are experiencing self-efficacy, which is to say, the belief based on experience that there are things you can do to move the needle in your life in a way that is positive, in a way that you want. If you experience that, you are highly resilient. And neurofeedback is a very direct body level way of developing self-efficacy. Finally, neurofeedback lets you measure progress. It allows you to consider in pretty specific ways whether we have in fact moved the needle in terms of brain function, and to pair that with assessment in terms of psychological outcomes. I find that to be very powerful in terms of my work and kind of keeping me organized in the work that I do with patients. Okay, I'm going to hit a couple of case examples quickly, and then we're going to take some questions. The first is a case of amygdala-based anxiety. I'm going to mention here that what you're seeing is the TheraQ, which has been developed inside of the Divergence platform. This is based on a form of assessment that has been around for many years now. This is a well-established approach to neurotherapeutic assessment, and we're using statistics here that have been validated, and they're used in a variety of platforms. What I want to draw your attention to here is we're looking at the back of the head. Now, this is not the exact patient I was talking about, because that was about 20 years ago, but this is pretty much identical with what her brain happened to look like. And I'm just going to point out very quickly, we have these three arrows that I'm trying to point to. And what these stats tell us, I'll just say very quickly, these give us an idea of the brain's capacity to shut off that alarm. The brain's capacity to shut off that alarm has a lot to do with its ability to generate alpha. Alpha is a very specific brain state that in general throughout the brain is sort of associated with rest and repair, recovery, sleep, those kinds of things. And it has the specific role in the back of the head of calming that alarm. This first statistic is simply telling us when we go from eyes open to eyes closed, does alpha increase? Alpha is actually should increase. Even when you blink your eyes, you should get a little spike of alpha. We have evolved that way. There's evolutionary psychology reasons for this. So we're looking for a rise of at least 70% on alpha. This individual's dropped 5%. When he closes his eyes, he's getting less alpha. Okay. So that's one big marker. This would be thought of as a stress or trauma marker. And in fact, in this particular case, that was reflecting historical trauma. Secondly, this alpha flexibility score is telling us a little bit more about alpha, about its ability to shift. The flexibility of alpha. Can we move from a rest and repair to an alert and back to a rest and repair state? Or do we kind of have trouble toggling? Anybody who is, they have a stressful day at work and they come home and they can't unwind, pretty good chance they've got some alpha flexibility issues. Finally, the theta beta ratio shift is very similar to the alpha shift. This is telling me that theta and is also having trouble rising in relation to beta. There's something called the theta beta ratio that if anybody wants to know what that is, you can ping me after the session. Okay, all of these three things are a big flashing light that we have an amygdala-based case of anxiety. And as a clinician, I'm going to want to consider whether we need to address this, get them calm enough so that they can take advantage of some of the other things we can offer psychotherapeutically. Case 2, cortically based anxiety. This case is actually from April 11. This is a very recent current case that I'm working with right now. And I picked it because actually we've got 4 very important criteria in the front of the head. This is the anterior region, which means front. So we're dealing with the executive functioning. And what I'm going to say just very briefly, this is a different individual, by the way. This stat and this stat, the theta alpha ratios, are suggesting that we actually have too much alpha in the front. You can have too little alpha. You need that for rest and repair. You can have too much. It leads to inefficient functioning in the front of the head. So this is an individual who's going to have trouble with emotional regulation, with kind of the processing that we have to do to sort out our emotions. And that's compounded by these red zone scores on our friend, the theta beta ratio at F3 and F4. Both of those, all 4 of these suggest that we've got inefficiencies in the front of the head that we can train. We can down train those and help them make more and better use of psychotherapy, as well as function better in their lives. I'll just show you very quickly. This is a screenshot of TheraQ's Emotional Dysregulation Index. You will see what we've done across the top here. We have an overview, which basically looks at each of these regions. And then we have these indices where we have taken the particular indicators that relate to emotional functionality, and we put them in here. If they are in the yellow or red zone, they're in this indicator, and we have an index here, 5.5 out of 10 for this particular person. There are indices for sleep, where we pulled those indicators out for sleep, cognitive function, and stress and trauma. So this allows you, in the context of this assessment, to basically go right to the issue that you're wanting to take a look at. Instead of having to kind of thumb through the different locations, you can see at a glance in a particular screen what you might want to be dealing with. So if you have an individual who's experienced a lot of trauma, you might want to go first to the stress and trauma index, and it will give you exactly what you need to know out of the neurofunctional data in order to develop a neurotherapeutic treatment plan. Okay, that was a lot in a short amount of time, but I do want to leave. Lori, I gave us 8 minutes. I hope that's enough. We can take some questions.
We can do it. I've got some questions, so keep them coming in if you don't hear yours asked here. So first question that came up is, do you have any resources you can recommend for learning how to start intervening at the brain level? Like you spoke about at the beginning of the session.
Well, that's a great question. I actually am putting together, Laura, you and I haven't had a chance to talk about this. I'm putting together just a little short reading list that maybe we can post after. Okay. Sure. That's probably the quickest way to tell you. Just give me a day or 2 and it'll be available to you. Kind of a starter set.
A lot of people asked about posting the link to a symphony in the brain. So like last time, I will embed that into the recording, as well as give you the link when the email goes out. So sounds like a library is coming. Another question that came up was, I think this is more, can you verify? It sounds as though some patients might benefit starting with neurofeedback rather than therapy.
Boy, that's a great question. So the grad school professor in me wants to say psychotherapy starts the minute you pick up the phone or the minute you're in contact with people. But I think what you're talking about is sort of a formal psychotherapy treatment plan. There are definitely times I will start with some form of neurotherapy, but I'm not going to kind of leave them abandoned, to like just go put these electrodes on. It's not going to be like that. It's going to be more something like, I'll give you a very common example. You all may be aware that sleep dysregulation underlies many mental health conditions. And as clinicians, I have to say I'm guilty of it too. We tend to underestimate that. There are individuals that I want to start on a digital sleeping pill ASAP. out of the first session. I'm going to give them what they need in terms of the equipment so they can go home and start doing that, because that will tend to re-regulate pretty much the entire system in the brain in most cases. So I may definitely start with that. What's most common is I kind of do it concurrently, because neurotherapy nowadays, with the various platforms that exist, there's a number of options that you have. The platforms that exist, we can do remote training. And so they're doing most of that work outside of the psychotherapy session. So you don't have to think of it as either or. It's kind of a both and scenario.
That kind of leads right into the next question, which says, is there a protocol for sleep?
Yes. It's called the digital sleeping pill. There are other variants. I'm not sure I have time to go into the details of it, but I would just say there's a couple of pathways you can go for addressing sleep. And really the next step to answering that question would be, let's look at the assessment, because it really depends on what's going on in that particular person's brain.
Great. More questions are coming through. Dr. Brown, can you share which neurofeedback system you're using now?
I'm using many systems right now, actually. I would say that we're in kind of a golden age in neurofeedback and neurotherapy. Some of you who know me know I've been doing neurofeedback since dinosaurs ruled the earth. Back when my original mentor built his neurofeedback equipment in his garage, that was the equipment we were using. We are in a golden age right now. There are many platforms. Well, I don't know about many, but there's a number of platforms. They all have different use cases. It kind of depends on your clientele. It depends on what kind of where you see yourself headed in your practice. We have, I work with a number of platforms. I also represent True Bearing Academy. We are basically here to train and to provide support for clinicians who are wanting to get into this. And one of the things that we'll work with them on is use case. What is your particular situation, and what platform will work best for you?
Good answer. A question about the significance of the electrode placement in the TheraQ. Some devices, I'm just trying to understand here. So some devices can cover all 10, 20 spots. So is the device used kind of limiting the electrode placement?
Also a really good question. So, and this is I'm going to give the short answer because there's a longer answer to this as well. There are $20,000 to $25,000 systems that can cover 19 and more channels. That is absolutely possible. It gives you lots of options with all of those electrodes operating concurrently. However, in most neurotherapy, it is rare, in my opinion, that it would be advisable to train at all of those channels. You generally want to train at perhaps at most 4, possibly 5. It depends on the situation. And so what you want is a system that allows you some flexibility. And there's different systems out there that allow different kinds of flexibility. There's a system that has a single electrode that you can place in different locations. There's a system that Divergence has. I'm just going to pull this up. The Flex Cap. This is put out by BrainBit, and it has these dry electrodes, and there's 4 of them. So you have 4 channels that you can do that training with. It kind of gets down into the nitty-gritty of how protocols work as to why having the 19 channels is most useful for assessment. It's less useful for actual treatment. You generally can get the job done with 4 or fewer.
Question about anxiety. So does anxiety have the same impact on geriatric clients? And if it does, should the same neurofeedback protocols be used for them?
I am doing a lot of neurofeedback work with the elderly right now. Maybe it's my gray hair. I don't know. But yeah, there's a good bit of evidence that this can be useful at all ages. With seniors, one of the more common things I've run into, there are issues with anxiety. There's also with dementia. actual dementia. Neurofeedback does not prevent dementia, but it can mitigate the symptoms, and it can reduce the depressive appearing effects of dementia. So yeah, this can be very, very useful for seniors.
A bunch of questions just came in asking about what training academy you're affiliated with. It's True Bearing, which is
yes,
right here. I think that's another link we can add to the references and things that came from this session.
Yes. In a nutshell, as I said, I've been doing neurotherapy and psychotherapy for a long, long time, and I've been a college professor or university professor, have trained a lot of people in neurofeedback. And we're at such an incredible moment in neurofeedback. The technology has reached a point where, honestly, I believe this can be something that will be really important in the field of mental health in the decades to come. So I've literally taken my practice and turned it into True Bearing Academy, set up specifically to offer training and support to clinicians. So there's several of us inside, a number of us inside of True Bearing Academy. We're busy putting together training for different platforms. We have training available for most of the major platforms, either currently or we will within a month. And so if you're interested, you'll hear more.
Sounds good. A number of people are asking if you can use TheraQ with a crown, and the answer to that is no. Due to the sensor location, it's only available with the BrainBit Flex.
Right. One of the things I should mention about the BrainBit Flex is you can actually put those four electrodes in any of the 1020 locations. So it's an advantage of looking a little bit like a Russian cosmonaut. Is you can when you have that on, is you can actually be very flexible in a location for assessment and training.
Okay. I think we should wrap this up because we're just hitting a little bit past the top of the next hour. Okay. Dr. Brown's graciously put up a link to our next series that's kicking off on May the 4th, which is going to be hosted by me. So a lot of our prospects and clients, customers, are coming to us saying, I want to do this. I have no idea how to get myself out there. How do I even think about pricing this? How do I market it? How do I keep track of my devices? And I've got you there. So we're starting a new webinar series on pricing and marketing your practice. Our first session on May 4th is kind of saying, let this be a group-directed series. So you're going to tell me what's important for you to learn right away. We're going to prioritize all the items and then start month by month going through them. It's the same as this one. So you can register to save your spot and attend live, or you can register and get the recording sent directly to you, just like we do with these ones. So in a few days after I have a chance to process the recording and get it all going, we will email you this recording. We'll have some links to send you for some resources. We'll have these links so you can easily click on them to find out more about Divergence and find out more about Dr. Brown's training academy. It sounds like there's a lot of interest around that. And hopefully we'll see you on May 18th, where we're going to tackle a similar topic, neurofeedback and depression. All right. Thank you, everyone, so much for your time, and we'll see you in a month.
Thanks, everybody. See you soon.